The next rapid fire topic is going to be presented by Dr. Scott Levine. And the title of the presentation is the 2014 U.S. Preventive Services Task Force Abdominal Aortic Aneurysm Screening Guidelines Negligibly Impacted Repair Rates in Male Never Smokers and Female Smokers.
Hi, I'm Scott Levin, a general surgery resident at Boston University. I'll be discussing our project evaluating the impact of the 2014 USPSDF AAA screening guidelines on repair rates. The U.S. Preventive Services Task Force, or USPSDF, is an expert and independent panel appointed by the U.S. Department of Health and Human Services that recommends and influences insurance coverage of screening tests, including AAA screening. In 2005, the USPSDF recommended AAA ultrasound screening only in men aged 65 to 75 who had ever smoked. In 2014, the guideline was updated to recommend screening in men without a history of smoking, particularly in those with cardiovascular risk factors or family history of AAAs. We estimate that an additional 2% of U.S. adults would have met criteria for screening after this 2014 update. We estimate that the increased screening would have resulted in a 50% increase in U.S. adults with AAAs identified on screening warranting intervention. Furthermore, the USPSDF adjusted the guideline from advising against routine screening in all women to a neutral position on screening in women with a smoking history. We aim to determine whether the 2014 guideline updates resulted in more elective AAA repairs in male never smokers and female smokers. We queried the Vascular Quality Initiative, Endovascular Aortic Repair, or EVAR, and Open Aortic Repair registries from 2013 to 2018. The VQI provides details regarding aortic repairs from over 500 centers nationwide. Our sample included first-time elective EVARs and open aortic repairs. The exposure was USPSDF guideline updates in 2014. The primary outcome was number of AAA repairs. We implemented difference and differences analysis, a quasi-experimental method that adjusts for secular trends to isolate changes in repair numbers due to the 2014 USPSDF guidelines. Our diff and diff models compared changes in repair numbers in patient groups targeted by USPSDF updates, that is, intervention groups, to those in unaffected patient groups, that is, the control groups, before and after 2014. Our first model compared changes in repair numbers between male never smokers aged 65 to 75 targeted by the guideline versus a control group of male never smokers aged 76 to 85 who were not targeted by the guidelines. In this part of the study, there were 1,295 AAA repairs in male never smokers, the majority of which were EVAR. 58% and 42% were performed in patients aged 65 to 75 and 76 to 85, respectively. There were no significant changes in male never smokers aged 65 to 75 versus 76 to 85 undergoing repairs after guideline updates, average over 1.5 years and 4.5 years. However, when their primary insurer was Medicare, male never smokers aged 65 to 75 compared with those aged 76 to 85 underwent significantly more repairs over 1.5 years, a 4.6 percentage point increase, and over 4.5 years, a 3.7 percentage point increase. There were no significant changes in prevalence of family history of AAA or mean AAA size repaired in this subgroup over the study period. Our second model compared repair numbers between female smokers aged 65 to 75 and those aged 76 to 85 as the control. In this part of the study, there were 2,312 repairs in female smokers, the majority of which were EVAR. Comparing those aged 65 to 75 versus 76 to 85, there was no significant change in repairs over 1.5 years or 4.5 years, even when Medicare was the primary insurer. In conclusion, the 2014 USPSDF AAA screening guidelines were associated with modestly increased repairs in men aged 65 to 75 who never smoked, but only when their primary insurer was Medicare. There was no impact on repairs among women who had smoked. Higher grade recommendations and better adherence to guidelines may be requisites for change.
Really nice work, Dr. Levine. Really elegant analysis with the difference with this natural experiment. My first question: do you think? I mean, the reason you're not seeing that big difference is because there's still low uptake to screening. Like I mean, if you look at the literature, unfortunately a lot of these studies are well, not unfortunate, but a lot of, I mean, the screening ultrasounds are ordered by primary care and they're not aware of the guidelines, right? So that's where we need to tackle, like the primary care.
Yeah, thank you so much. That's exactly right. A lot of primary care providers are not aware of the USPSTF screening guidelines. And even surgeons haven't necessarily heard of the USPSTF guidelines, and so that affects implementation of AAA ultrasound screening, and and then uh, and then also, but what many people don't realize is that the USPSTF has major influence over insurance coverage of the AAA's ultrasound screening, and grade A and B recommendations are covered by insurance. So they have enormous influence.
And I mean, in the new like the new like the USPSTF guideline, I mean, there was not major change, right? So if you were in charge, what change would you make?
Right. That's a great question. And yes, there were no changes. It's effectively the same. Still, they're not advocating for female smokers to be screened. And we know they are at high risk for developing AAAs. And that's one change I think eventually I would hope to see is that this group would be covered. And even male never smokers with a family history of AAAs and other cardiovascular risk factors it seems some of the literature supports that they benefit from screening. So I think we need more research, more randomized controlled trials, prospective data demonstrating the benefit of screening these patient groups, and then hopefully the USPSTF will evolve to give higher recommendation screenings in these groups.
And BQI does not capture if the patient had or not a screening, so that would be something that would,
yeah, that would, yeah.
And when you went through your analysis, I mean, obviously a lot of the changes that the USPSTF does is because of, I mean, looking at if there's going to be any change in prevalence, because that's when there may be a change if these screenings are cost effective or not. And with I mean, we unfortunately, it hasn't been a big prevalence study on Medicare population lately, so we don't know. But if with the numbers that you're getting, that I mean, it looks like there hasn't been a big change in the last 10 years, right, on numbers.
Right. So I think yeah, we'll have to hopefully we can get more data on the ultrasound screenings in this population, in these populations, and then and continue to collect this data and show its the impact on these subpopulations prospectively.
No,
Yeah, the moral of the story is we need more data in these subpopulations to show the benefit of screening, and then hopefully the guidelines will follow.
no, but congratulations, because with a difference in difference, it's as close as you get to level 1 data. So really elegant study. Congrats again.
Thanks so much.
And I don't think we have any more questions. So congrats again, and we'll move forward.